I'm Rod Rourke, and I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi, and welcome to the January 2017 edition of the PRS Journal Club podcast. I'm Chad Purnell, the PRS Resident Ambassador from Northwestern University, and I'm joined by my co-ambassadors Jordan Frey from NYU and Shuja Shafqat from Lehigh Valley. Today we have the honor of being joined by Dr. Maurice Nahabedian, Professor of Plastic Surgery at Georgetown University. The article we'll be discussing next is Skoog Primary Periosteoplasty versus Secondary Alveolar Bone Grafting in Unilateral Cleft Lip and Alveolus, Long-Term Effects on Alveolar Bone Formation and Maxillary Growth, by authors Drs. Jabari, Hakelius, Thor, Reiser, Skoog, and Nowinski. Remember, all these articles can be read for free on PRSjournal.com, including an archive of all past Journal Club articles. So just to give a quick overview of this article, this is a paper out of Uppsala University in Sweden, and what the author's goals were to evaluate the technique of primary gingivoperiosteoplasty, which was initially described by Tord Skoog. And basically this is elevating the gingiva around the cleft alveolus with the idea of whenever you primarily repair that gingiva, this may spontaneously form bone in the cleft alveolus. They wanted to compare this technique versus their newer technique, which is a more traditional iliac crest bone grafting at the age of mixed dentition. So how the study was designed was basically, this is a retrospective cohort study with two single surgeons. Each surgeon was operating at a different time period and utilizing a different technique for closure of the alveolus. So of these two consecutive groups, so the first group was 28 patients who had an original Skoog type repair from Tord Skoog himself between 1960 and 1977. So these patients had their primary gingivoperiosteoplasty at age 4 months on average. And this was compared to a group of 29 alveolar bone graft patients who were performed by Valdemar Skoog between 1978 and 1998, and these patients had their procedure performed around 10 years of age. Importantly, none of these patients received any type of pre-surgical orthopedic treatment prior to their treatment of their alveolus. So impressively, each group was followed for at least 18 years, and they were evaluated in multiple different ways. The first thing that they looked at and compared was the need for an additional bone graft procedure, so whether the patients didn't form enough bone and required a secondary bone graft after their first bone graft or their primary gingivoperiosteoplasty. Other things that they looked at were their maxillary and mandibular growth, and these were assessed by lateral cephs at multiple time points. They assessed the SNA, SNB, and ANB at these times. And finally, what they looked at were occlusal x-rays, and whenever they were looking at occlusal x-rays at all of these time points, they were evaluating the alveolar height. And this was compared using the Berglund index, which is a method of measuring the height of an alveolus compared to a normal alveolus. And so what the authors found were that whenever they looked at the need for a secondary bone graft, the primary periosteoplasty group really required a significant amount of secondary bone grafting after their gingivoperiosteoplasty. So of the 28 patients that had a GPP, 13 of those later required a secondary alveolar bone graft, and actually 4 additional patients were offered an alveolar bone graft due to significant loss of alveolar height, but they refused. So actually a 60% rate of revision surgery in the primary periosteoplasty group. The secondary alveolar bone graft group didn't require any additional bone grafting after their first procedure. As you might imagine, looking at that data, the alveolar bone height was significantly improved in the patients who had their alveolar bone graft from the iliac crest at the age of mixed dentition. So that was statistically significant data. The Berglund index was much worse in patients who had a primary periosteoplasty. Whenever they looked at maxillary growth, as assessed by SNA, at the endpoint, skeletal maturity 18 years, this was equal between groups, but in patients who had a primary periosteoplasty, they had more growth restriction in the early ages prior to whenever the other patients had had their secondary bone graft. And whenever they compared to age-matched normals, both groups, whether they had an alveolar bone graft or they had a gingivoperiosteoplasty, both had restricted growth compared to normals. Interestingly enough, they also looked at SNB, so the mandibular relationships of the patients, and in the alveolar bone graft patients, the mandibular protrusion was increased at both age 10 and age 18 compared to the periosteoplasty group, although there wasn't really a great explanation as to why this might be happening. And finally, whenever they looked at A and B, so the maxillomandibular relationship, this was greater in the primary periosteoplasty patients at both 5 and 18 years. So overall, the gestalt for this article is that the authors recommended abandoning the technique of primary periosteoplasty as it was initially performed by Tord Skoog, as it results in less bone formation, although it didn't appear to affect the end growth of the maxilla as compared to a regular alveolar bone graft. And in fact, the authors actually almost 30 years ago, actually almost 40 years ago, had already abandoned this technique of primary periosteoplasty, but this is the first comparative data they had to show the reasons why they had abandoned this. So, Dr. Nahabedian, I wanted to ask you, I know that you're not a craniofacial surgeon, but there's a lot of single surgeon data out there in the literature. And this is another paper that shows some single surgeon data. And the authors, in fact, mention that surgeon skill in cleft surgery is an important factor in the success of a procedure. So do you think that whenever basically single surgeon data is being published, that this is still important, or should we be moving kind of beyond these types of studies and moving to more multiple surgeon or multi-institutional studies in order to answer these questions better?
There's a lot of value to high-level studies and then maybe studies that maybe aren't as high level of evidence. So oftentimes a single surgeon study may be retrospective and classified as a level 3 or a level 4 study, but there's still a lot of value and there's a lot of good information that can be extracted out of those studies. And sometimes it can be even more useful than a level 1 or a level 2 study. I mean, what I like about this study is it's such a longitudinal study covering a span of about 40 years with two surgeons who are doing two different operations. And they basically found that the initial operation, when followed for years out, wasn't as effective as they thought it was going to be, and they made modifications and changed things around from the primary periosteoplasty to then doing the secondary alveolar bone grafting. So I think that this really does demonstrate some useful information, and it kind of goes over the whole learning curve and how we start off doing one operation but then evolve and do something else. I mean, I can translate this into what we do with breast. I mean, I did a lot of total muscle coverage and partial muscle coverage of devices and then evolved into some of these other techniques that I didn't do 20 years ago. And this, I think, is another example of how things change and how we evolve and how we learn.
I agree, and I think just as somebody who is a little bit of a craniofacial nerd, the idea of being able to look at these original Tord Skoog patients from 1960 and to see what his long-term follow-up was really interesting, and so I found this to be a really interesting paper. One of the kind of strange data points in this paper was that the mandibular position differed between the primary periosteoplasty group and the secondary alveolar bone grafting group, but really, logically, neither of these procedures should affect the mandible. So do you think this is just evidence of confounding, or that the sample size was too small?
Yeah, it's hard to know because, I mean, it's kind of an outlier data point. I'm not really sure what the real relevance or significance of it is because, they're obviously working on the maxillary segments and they're getting some mandibular effects. So I don't really have a good understanding as to why that would be unless there are some other issues related to growth factors or, hormonal influence that regulates some of the bone growth, especially during the mixed dentition period. It's hard for me to know and extrapolate why that would be, but certainly it might be worth further inquiry.
Yeah, I think this is interesting, especially looking at kind of a joining between two fields with soft tissue and bony growth. And I'd urge a lot of the people listening, especially more junior residents, there are some great CME articles in PRS about bone biology and how bones grow. And it's something that I think we don't necessarily learn as well or place a big emphasis on in plastic surgery. So I'd always urge some junior residents to go read those papers. And just another question, Dr. Nahabedian, is the potential donor site morbidity of alveolar bone grafting from iliac crest now nearly fully mitigated by advancements such as Acumed Harvest and Exparel for pain control? And then I'd be interested to hear some of your thoughts in general on some of the more recent enhanced recovery after surgery and plastic surgery and pain control options that you have for some of your patients as well.
technology has really kind of evolved in this area, especially when it comes to bone grafting. And I mean, some of these Acumed techniques, minimally invasive, and you can really morselize bone graft from different areas of the body, whether it's iliac crest or radius. I think that can be done efficiently without having big incisions and big chunks and then having to do everything manually. And combining those enhanced harvesting techniques with postoperative pain control, especially with some of these enhanced recovery algorithms that we have now, using Exporel, for example, I think can really eliminate the pain response for anywhere from 2 days to 3 days. So I think some of those donor sites that historically were very painful and uncomfortable can now be better controlled. So I think that alveolar bone grafting may not be as uncomfortable for patients as it once was because of some of these advancements that we have with pain management and harvesting techniques.
I think another interesting point with this paper, and it's kind of been touched on, is that in the long term they found that there were actually no differences in terms of maxillary growth between the two techniques, and that the periosteoplasty patients eventually caught up. But it's so great with this paper, like we mentioned, that over 40 years they followed these patients, and I think it's so important for us young residents going to become young attendings that really need to follow our patients and keep seeing them no matter what we're doing, to really identify what are our outcomes, where are we being successful, where are our shortcomings, and what can we do better, and continuing to improve regardless of what we're doing.
Totally agree. I think there's no substitute to having patients come back every 1 or 2 years and keeping a database. It's more work for surgeons, but I think the information you gain from keeping track of every patient, that's the best way to learn. And then you'll find that we're not really that different, that other studies will actually corroborate with what you think. But I think keeping an accurate database and seeing patients every 1 or 2 years, there's no substitute for it. I think it's just part of being a good doctor.
Dr. Nahabedian, thanks very much. I think that's actually a perfect endpoint to end our discussion. I think that all three of these articles that we discussed show the importance of keeping track of our patients and following our patients. We may not need to follow them for 18 years like this paper, but I think it's important that we all track our results because it's the only way to really understand the outcomes that we're getting from surgery. With that, I wanted to thank you very much. We'll end our discussion of this article, and remember to tune in to the other 2 articles that will be discussed on this month's podcast, as well as the PRS Journal Club podcast that we broadcast every month. Also, don't forget to participate in our monthly Twitter #PRS Journal Club, where we'll be able to interact directly with this month's selected articles' authors. Thanks again, Dr. Nahabedian. We really appreciate you joining us this month.
Thank you very much. It's been a pleasure.